In this lecture, we're going to cover the ENT infections. That is the ear, the sinuses, and the throat. This is stuff that can be applied to pediatrics or to adult medicine, but usually comes up in the pediatric shelf. We'll close the back half of this lecture off with a couple of the diseases that are a little lower yield, but generally occur on the peds shelf. They're generally not worth showing up on the STEP exam. So let's start off with the infections of the ears, nose, and throat, knowing that it can be applicable to adult and pediatric medicine. And we'll start off with otitis media, the typical earache. Otitis media is generally going to be caused by the upper respiratory tract infection bugs, and that is strep, varicella, and H-flu. And this is going to be an infection, otitis media, of the middle ear. And I don't mean the middle of the ear canal, I mean the tympanic membrane. The vestibular apparatus is okay, the pin is okay, it is the tympanic membrane that's affected. The patient is going to present with a painful ear. It is a unilateral ear pain. And that pain is going to be relieved with pulling of the pinna. You're going to see why that is relevant in just a moment. So it's going to be a kid whose ear hurts, they're tugging on their ear, trying to get relief of that sensation, and it doesn't come. But pulling on the ear doesn't make it hurt anymore. You say, okay, there's a problem with the ear, so I'm going to look in. And otitis media is going to be swelling of the tympanic membrane. So you'll see words like loss of the light reflex, a bulging erythematous tympanic membrane. And what you ought to see is fluid behind the ear. But none of these things are diagnostic of otitis media. The only thing is actually a physical exam maneuver. The diagnosis is made clinically with pneumatic insufflation. That is, while you're looking in the ear, you puff some air. If the tympanic membrane stays rigid and doesn't move, you've got otitis media. Now, the treatment for otitis media is sort of difficult. What I want you to remember is the first-line therapy is amoxicillin. For those who recur, you're going to add to amoxicillin clavulanate. For those who recur and recur and recur, you're going to do ear tubes, which is tympanoplasty. And you'd use ear tubes if you've had 3 occurrences in 6 months or 4 occurrences in a year. Getting deeper into the 270 range, if you are pen allergic, what do? If you have a pen allergy and it is non-life-threatening, that is not anaphylaxis, it's okay to use a cephalosporin, first or second generation, like ceftonir. And at the very bottom of your tools to treat otitis media, if they're pen allergic and they had anaphylaxis, then you can use azithromycin. And this makes intuitive sense. Azithro is used to treat bronchitis caused by the upper respiratory tract bugs, but it's just not a very good treatment for otitis media, so you generally want to stay away from it. Well, if we're talking about otitis media, the next one we should compare it to is otitis externa. And as the name implies, this is going to be an infection of the outer ear. That is the pinna and the canal itself. And there's 2 ways you can do this. The first way is swimmer's ear. That is someone who gets exposed to water, either through showering or through swimming, but doesn't dry their ear, and they get infected with Pseudomonas. Or it's digital trauma. That is someone's trying to dig in there to get out the wax, they keep picking at their ear, put a Q-tip in there, break the skin, and that leads to staph. The patient is also going to complain of a unilateral ear pain. And here's why it matters so much, and why I spent so much time on that pulling of the pinna. The pain is made worse with pulling the pinna. The exact opposite of otitis media. And when you look down the canal, you're going to see the outer ear, the canal itself, be erythematous and angry. And you're not going to see a bulging tympanic membrane. Otitis externa is also a clinical diagnosis. And the treatment is actually do nothing, right? Otitis externa usually resolves spontaneously. If it doesn't, or it looks like malignant otitis externa, that is, the person is toxic, then you can use eardrops. So the trouble is that waiting is right and using antibiotics is right. To pick on the test, what they're going to give you is someone who's obviously sick with a really nasty ear, treat that with antibiotics. Someone who's got a little bit of earache and a little bit of erythema, spontaneous resolution. If you're going to treat, you're going to use both antibiotic drops, usually Cipro to cover the Pseudomonas, and steroid drops to make them feel better. But if you're considering something about the ear, you want to make sure they don't have a surgical emergency, and that is mastoiditis. This is going to be caused by the same bugs and should be considered in anybody who's got otitis media and otitis externa, especially if you've got ear tubes, which makes sense. You got a hole in the tympanic membrane, you're going to allow the external environment into the middle ear. And this is an infection of the mastoid bone. So you're going to see a person who looks like acute otitis media, and they're going to have mastoid swelling. So you're going to have swelling behind the ear, and they might have an anteriorly rotated ear. This is a clinical diagnosis as well, and just know that yes, you can get the CT scan to show you that, hey, the mastoid is involved. No kidding, if this is all swollen and their ear is rotated forward, you don't need the CT scan. The treatment is surgical decompression. And presumably, you're already treating them for otitis media, so they're on antibiotics already. Now you've noticed the mastoiditis as a complication, so you get them to surgery. That's the ear. Let's move a little deeper and start talking about sinusitis. And a lot of what you do in ENT is try to decide, is this going to resolve spontaneously? That is it viral? Or do I need to do something about it in the way of antibiotics? And the reason why it becomes so important, as we'll see in pharyngitis, is the complications of not treating. So with sinusitis, you're going to have to find out, can I just let this go? Or do I actually need to treat it? So let's talk about bacterial sinusitis first, the thing you should treat with antibiotics. The path of sinusitis is going to be the upper respiratory tract infection bugs, usually strep. And the patient is going to present with congestion. You've probably had a cold before, and you know what that's like. But bacterial sinusitis has something very specific about it. It's not just a runny nose and feeling congested. You're going to have bilateral purulent discharge. That is, it's going to be thick, white, and smelly. And it's going to come from both noses. It's not just a leaky faucet, it's nasty. And if you do a facial tap, you're going to produce pain. Now, you know already this person is a little toxic, they got purulent drainage, they have a sinusitis, which is probably bacterial. You're going to get tricked by the test to try to get some sort of imaging, right? X-ray, CT. Both are wrong and should not be done. If you did an X-ray, you'd see air fluid levels, and they might give you the X-ray. You did the special one where you're looking up, otherwise all you're going to do is take a picture of their skull and you won't see anything. And the CT scan is going to show you opacification. You're going to see which of the sinuses is involved, but you don't need those tests to treat, so don't do them. And the treatment is going to be supportive, unless it is so obvious that it's bacterial. It's probably viral, in which case you just watch and wait. Now, if they give you thick, bilateral, purulent nasal discharge and the person has a temperature, temp greater than or equal to 38 degrees C, or it's been going on a long time, that is duration greater than 10 days, or it got better and then worsened, or it's worsening in general, this is an or statement, any one of these means give me penicillin. usually in the way of amoxicillin, clavulanic. But the supportive approach is used when someone has just a regular cold, what I call nasal viral. You've definitely had this. This is usually caused by rhinovirus, and if you have not had it yet, you will after your PEDS rotation, because it is spread by air droplets. And kids going around sneezing on and touching everything and touching every surface, you're eventually going to encounter one of these viruses that you maybe haven't seen in a while. So you're going to get a little nasal viral, right? You're going to get a little cold. You are going to be congested. But it is bilateral, clear rhinorrhea. Now, if you heard that statement in a traumatic setting, you're going to think CSF, but it's just really runny and it's copious. And the test is going to ask you to do the same thing, right? You think it's a cold, so maybe get the X-ray and the CT scan. Well, you know not to do that. But where they might trip you up is say, are you sure it's a cold? They might give you the opportunity to do PCR on the nasal washings or immunofluorescence. Well, if you think it's a cold, you don't want to go wasting money, so don't do either of those. And they might say, well, you have to be certain it's not bacterial, so you should get a culture. Don't do that either. If you have bilateral, copious, non-toxic patient with lots of rhinorrhea, it's simply a cold, and all you need to do is be supportive. You might give a little bit of medications to dry them out, to make them feel better, but really you need to do nothing in the way of active treatment. Now, just as an aside, both of these conditions may warrant a CT scan. And that is going to be the person who has recurrent sinusitis, especially recurrent bacterial sinusitis, trying to find an anatomic defect that limits drainage. And if you're talking about kids, and we'll talk about this in a minute, if you see bacterial sinusitis, consider a foreign body. Now, the last of the high yield is going to be pharyngitis. And in pharyngitis, we again have to decide, is this going to be viral or is it strep A? The pathogenesis is either going to be viral, which is the case most of the time, or group A strep. And the reason why a group A strep is so important is that if they have group A strep pharyngitis and you don't treat it, they get rheumatic fever. Just as an aside, impetigo and pharyngitis with strep, the risk of post-streptococcal glomerulonephritis is not reduced by treating it. You treat pharyngitis to reduce rheumatic fever. And the person with pharyngitis is going to present with a sore throat. And it's going to be razor blades when they swallow, so odonophagia. The rest of this patient presentation is going to be the Centaur criteria. I want you to know about it. I want you to memorize it. I want you to practice based on what the Centaur criteria tells us. Just know that in reality, it really hasn't held up to the test of time, especially in the way of kids under 14. So the modified Centaur criteria tries to bring that in, but we know that group A strep happens more often in younger kids and less often in adults. So the Centaur criteria has a few limitations, but for you on your wards and on your test, memorize the Centaur criteria and practice based off it. And if you look down at the discuss boards, one of our members has actually come up with a mnemonic for the Centaur criteria. Now remember, the first one is negative, that is no cough. The second is exudates. N is nodes for lymphadenopathy, and T is temperature greater than or equal to 38 degrees C. And the OR tries to get at that age thing. If you're less than 14, you get +1. If you're older than 44, -1. The absence of a cough, presence of exudates, presence of anterior lymphadenopathy, and the presence of a fever all give you +1. The score tells you what to do. The diagnostic step or the treatment is based on the Centaur criteria. If you're less than or equal to 1, it's viral, do nothing. If you're 2 to 3, you're going to do a rapid strep. And if you really thought this person had group A strep and the rapid strep is negative, you can follow it up with a culture. If you thought they didn't have it and the rapid strep is negative, then you can follow it up with do nothing. That is reassurance or supportive care. If the Centaur criteria is greater than or equal to 4, then you're just going to treat with antibiotics. Now this is tricky because the IDSA says, well, we want to know that was a bacterial strep, so get the rapid strep anyway. The way I want you to practice on the test is simply to follow the Centaur criteria, knowing that in the back of your mind, one guideline says, no matter what, get the rapid strep. And the treatment is going to be amoxicillin clavulanate. Now, just as an aside, if you're going to treat someone for strep pharyngitis because their Centaur criteria is high, you're going to pick amoxicillin clavulanate after you do the rapid strep and it's positive. But someone could have a sore throat. And if someone has a sore throat and a big spleen, that's probably mono, that is EBV, and you want to do the mono spot to try to diagnose the mono. Separate disease, but it is one cause that you can actually go after. All right, so this was the first half of the ENT lecture. It's applicable to adult medicine as well as pediatrics. You just see it more often in peds. And so I want to go through it one more time, making the highlights. Otitis media is unilateral ear pain relieved by pulling on the pinna, pneumatic insufflation, amoxicillin, tubes if it recurs. Otitis externa is going to be a big nasty looking ear. When you pull on the pinna, it hurts. Use Cipro antibiotic drops with steroids if they're really bad. Otherwise, it'll resolve spontaneously. If you're giving consideration to an ear infection, make sure they don't have mastoiditis by looking at a big bulging thing behind their ear. A CT scan can be done if you're not sure, but really where you should go is, no, I don't need a diagnostic step. I know they've got mastoiditis, refer them to surgery. Sinusitis, what you're looking for is bacterial versus viral. If it is purulent bilateral drainage, or it's been going on for 10 days, or they're toxic appearing, just treat them with amoxicillin and clavulanate. Regardless, don't try to make a pathological diagnosis. You don't need the micro, culture, washings, whatever. Don't do any of that stuff. Just decide, am I going to treat with antibiotics, or am I going to wait, knowing that you can look for foreign bodies or do a CT scan if it recurs. And lastly, pharyngitis, what you're going for is this strep? Use the Centaur criteria to stratify into reassurance, do a rapid strep, or just treat empirically. Keeping in the back of your mind, if they mention something about a spleen or sharing cups during a frat party, think about mono. Let's transition and talk about the back half of this lecture. A few diseases remaining, low yield, peds only. On the back half of this Peds ENT lecture, let's talk about 3 more diseases that are a little lower yield, but still fair game. Let's start off with foreign body. And we're talking about in the way of foreign body is, this is how you get the bacterial infection. And what you're probably going to do as the provider is say, okay, well, I see a bacterial ear infection, a bacterial sinus infection, so I'm going to look up there, and you see the object. But foreign bodies come in kids because kids like to stick things places. And generally the story is going to be something along the line of the caregiver leaves the kid unattended for just a little bit and an object is gone. But in the setting of ENT, the caregiver is not even going to realize that it's happened. Instead, you're going to get a unilateral infection, a bacterial infection, that prompts you to give antibiotics, and then you take a look. And the diagnosis is made based on clinical inspection. We talk more about this in the pulmonary lectures, where if an object has been aspirated, it's a little more involved because you can't just see it on visual inspection. But in the EN area of ENT, what I want you to see is that you are going to find something that prompts you to look, and then you see it. The treatment, of course, is going to be to treat the bacterial infection, but then retrieve the object. And for ears and nose, that's going to be forceps. You basically have tweezers. And again, we'll talk more about this. Do you do a rigid bronchoscopy because it's in the trachea, or do you do an endoscopy because it's in the GI tract? We can extrapolate this to adults to include the homeless population. And the homeless know about this, so they will put coins in their ears when they sleep. That's to prevent insects from crawling in. And so if you've got unilateral ear pain and maybe even some drainage, but there is either scratching or buzzing, that is an insect in the ear canal. Do not shine a light down the canal. Being an insect, it will run from the stimulus and try to burrow deeper into the ear. Don't do that. Instead, what you want to do is use lidocaine to paralyze the insect and then retrieve it. That's foreign body. Let's talk about epistaxis, nosebleeds. In kids, almost always epistaxis is going to be digital trauma. That's the medical terminology for nose picking. And a nosebleed is normal if it's a unilateral bleed, that is only one nostril is involved, and it lasts less than 30 minutes. Again, going to adults, you might have a coagulopathy, there might be alcohol on board, but for kids, it's usually digital trauma or some sort of sports play injury, and the bleeding should stop right away. The diagnosis is, of course, clinical. And the treatment, and this is where you can help educate some of the adults, is to lean forward and apply pressure or ice. If you lean back and pinch your nose, all you're doing is swallowing or potentially aspirating blood, and then when you cough, you dislodge whatever clot you formed and you're back to square one. If you lean forward and let the blood drip into the sink or the toilet bowl while you're applying pressure, eventually it will stop. If it doesn't, you may need to do a little bit more, and so that's where the ENT is going to come in and look up at the nose through the nair. If you've got an anterior bleed, you will cauterize, usually with nitrate sticks. If it's a posterior bleed, you instead will do packing. And if you pack somebody for a posterior bleed, you need to make sure you put them on prophylactic antibiotics to make sure they don't get toxic shock. It's epistaxis. Let's close off with the only disease we've talked about that is strictly pediatrics, choanal atresia. And what this means is that the path from the nose to the throat is somehow blocked. And either it is completely atretic or there is some sort of stenosis. The idea is you can't get air through the nose into the throat, into the trachea. No problem if you breathe through your mouth. So what you're going to see is when the mouth is occupied doing something else, baby can't breathe. So baby will turn blue, cyanotic, with feeds, but then will pink with crying. That is to say, while baby is feeding, it's nursing, its mouth is doing something else, it has to breathe through its nose. But when it's crying, mouth is wide open, air moves fine. The other thing that might tip you off, not in infancy, but in early childhood, is if you have a childhood snore. They haven't had enough time to develop obesity to get obstructive sleep apnea, so childhood snore, but also blue with feeding, pink with crying, suggestive of choanal atresia. The way you make the diagnosis is actually pretty easy. You pass a catheter, and a catheter will fail to pass in a complete atresia. If you're worried about stenosis, you might have to look up there with a fiber optic wire. But once you diagnose the stenosis or the atresia, you have to surgically open it up. So the first half was the high-yield diseases, otitis, sinusitis, pharyngitis. The back half was lower yield, but still fair game, talking about foreign bodies. Remove them when you find them, and don't forget about bugs. Use lidocaine before you shine a light down someone's ear. Epistaxis, which should stop within 30 minutes. If you have an anterior bleed, you can burn it. Posterior bleeds need packing plus prophylactic antibiotics. And then choanal atresia is going to be the snoring baby who pinks up when they cry but turn blue when they feed, and a catheter fails to pass. That is PEDS ENT.